The liver performs different kinds of biochemical, synthetic, and excretory functions, so there is no one biochemical test can detect the global functions of the liver. Liver function test therefore refers to a battery of tests for initial detection and management of liver diseases. A good clinical history and physical examination plays an important role to interpret these liver function tests in managing your patients. The liver function tests, basically they are used for screening, as they are the non-invasive yet very sensitive screening modality for liver dysfunction. They are helpful to recognize the pattern of liver disease, also used to assess the severity and predict the outcome of certain diseases such as primary biliary cirrhosis. They can be used on follow-up of certain liver diseases and also help in evaluating response to the therapy like autoimmune hepatitis. There are some limitations to these liver function tests, such as they lack sensitivity. The liver function test may be normal in certain liver diseases. They also lack specificity and are not specific for any particular disease. Except for serum bile salts, the liver function tests are not specific for liver diseases, and all the parameters may be elevated for pathological process outside. They can be classified to test of the liver's capacity to transport organic anions and to metabolize drugs, tests that detect injury to the hepatocytes or the serum enzyme test, and tests of the liver's biosynthetic capacity. Let us start with the test of the liver's capacity to transport organ anions and to metabolize drugs. In this class, we have tests like serum bilirubin. And bilirubin refers to an endogenous anion that's derived from hemoglobin degradation from the red blood cells. The classification of bilirubin is into direct and indirect bilirubin and is based on the test known as Van der Berg method of measuring bilirubin. We're going to look at it in details. Then bilirubin is altered by exposure of light to serum, and plasma samples must therefore be taken in a dark environment before measurements are made. When the liver function tests are abnormal and the serum bilirubin levels are more than 17 micromoles per liter, they will suggest an underlying liver disease. Total bilirubin is a measure of the amount which reacts with 30 minutes after addition of alcohol or ethanol. The normal range is 0.2 to 0.9 milligrams per deciliter and is slightly higher by 3 to 4 micromoles per liter in males as compared to females. The second type is called direct bilirubin, and it refers to the water-soluble fraction of bilirubin. It is measured by reacting with diazoxide sulfonic acid in 1 minute and gives estimation of conjugated bilirubin in blood. Therefore, the normal range is 0.3 milligrams per deciliter, that's equivalent to 5.1 micromoles per liter. And the third type is called indirect bilirubin, and this is the fraction calculated by the difference of the total and direct bilirubin and is a measure of unconjugated fraction of bilirubin now. Hyperbilirubinemia will result from overproduction or impaired uptake, conjugation increased conjugated bilirubin, impaired intrahepatic excretion, or regurgitation of unconjugated or conjugated bilirubin from the hepatocytes of the bile ducts. Therefore, serum bilirubin could be lowered by drugs such as salicylates, sulfonamides, free fatty acids, and they can be elevated if serum albumin increases and the bilirubin therefore will shift from tissue sites to circulation. In fulminant hepatic failure, deep jaundice is associated with increased mortality, and this is the prognostic value of bilirubin levels. We have the second type known as urine bilirubin. The presence of urine bilirubin indicates hepatobiliary disease, and unconjugated bilirubin is tightly bound to albumin and is not filtered by the glomerulus, and therefore it's not present in urine. Conjugated bilirubin may be found in urine when the serum bilirubin levels are normal because the renal threshold of conjugated bilirubin is very low, and the lab values can detect very low levels of this conjugated bilirubin. We have another type known as urobilirubin, and an increase in urobilirubin in urine is a sensitive indicator of hepatocellular dysfunction. It is also a good indicator of alcoholic liver damage or well-compensated cirrhosis or a malignant disease of the liver. It appears early in urine in viral hepatitis and markedly increased in hemolysis. Urobilirubin gives a purple reaction to enriched aldehyde reagent, and a dipstick containing this reagent allows a rough and ready quantification of this urobilinogen. For you to measure urobilinogen levels, you use a freshly voided urine in your testing. We can move tests to the test that detect the injury of hepatocytes, or rather, we start from the enzymes that detect hepatocellular necrosis. And these enzymes are known as aminotransferases. These aminotransferases are a specific indicator of hepatocellular necrosis. They are two in number, that is the aspartate aminotransferase, or known as serum glutamate oxaloacetic transaminase, SGOT, and alanine aminotransferase, ALT, or serum glutamic pyruvate transaminase. They catalyze the transfer of alpha amino acids of aspartate and alanine respectively to the alpha keto group or ketoglutaric acid. ALT is primarily localized to the liver, but the AST is present in a wide variety of tissues such as the heart, skeletal muscle, the kidney, brain, and the liver. AST is therefore present in both mitochondria and cytosol of hepatocytes, as compared to ALT, which is localized inside the cytosol only. The cytosolic and mitochondrial forms of AST are true isoenzymes and immunologically distinct. A large increase in mitochondrial AST occurs in serum after extensive tissue necrosis. And mitochondrial AST is also increased in chronic liver disease, and virtually there's no aminotransferases in urine or bile. Hepatic sinusoids are the primary site for their clearance of these aminotransferases. These aminotransferases are increased in every liver disease, and the highest elevation occur in severe viral hepatitis, drug or toxin-induced hepatic necrosis, and circulatory shock. And moderate elevation occurs in acute hepatitis, neonatal hepatitis, chronic hepatitis, autoimmune hepatitis, drug-induced alcoholic hepatitis, and acute biliary tract obstruction. The ALT is usually more frequently increased as compared to AST, except in chronic liver disease. In uncomplicated acute viral hepatitis, the very high initial levels approach normal levels within 5 weeks of onset of illness, and the normal levels are obtained in 8 weeks. Disproportionate low in patients with Wilson disease. A mild elevation is observed in sepsis-induced neonatal hepatitis, extrahepatic biliary atresia, fatty acid, fatty liver, cirrhosis, non-alcoholic steatohepatitis, drug toxicity, myositis, Duchenne muscular dystrophy, and even after vigorous exercise. The ratio of AST to ALT is of use in Wilson disease and chronic liver disease and alcoholic liver disease, together with a ratio of more than 2 is usually observed. The lack of ALT rise is probably due to the pyridoxine deficiency in these patients, and in non-alcoholic steatohepatitis, the ratio is less than 1 in the absence of fibrosis on liver biopsy. In viral hepatitis, the ratio is usually less than 1. The ratio of invariably rises for more than 1 as cirrhosis. ALT exceeds AST in toxic hepatitis, viral hepatitis, chronic active hepatitis, and cholestatic hepatitis. Falsely lower aminotransferase levels are observed on patients on long-term hemodialysis, secondary to ATA disylate and pyridoxine deficiency. Also, low levels have been observed in uremia. And some other enzymes used to assess this hepatocellular necrosis include glutamate dehydrogenase, isocitrate dehydrogenase, lactate dehydrogenase, and sorbitol dehydrogenase. The enzymes that detect cholestasis. These are alkaline phosphatases. Alkaline phosphatases are a family of zinc metal enzymes with a serine at the active center. They release inorganic phosphate from various organic orthophosphates and are present nearly every tissue in the body. In liver, alkaline phosphatase is found histochemically in the microvilli of bile calaniculae and on the sinusoidal surface of hepatocytes. Alkaline phosphatases from the liver, bone, and kidney are thought to be from the same gene, but that from the intestine and placenta are derived from a different gene. This one has a significance in your diagnosis. In healthy people, most circulating alkaline phosphatase originates from the liver or the bone. The reference method used p-nitrophenol phosphate as a substrate in our alkaline buffer, and fresh and hemolyzed serum is the specimen of choice for this estimation. The test should not be done on plasma if citrate, oxalate, or EDTA were used as anticoagulants because they form a complex with zinc and alkaline phosphatase causing an irreversible enzyme inactivation. The interpretation of these results from alkaline phosphatase, average values with age are relatively high in childhood and puberty, and lower in middle age and higher again in old age. They start with a very high, then come to lower, become elevated. Males usually have higher values as compared to females, and highest levels of alkaline phosphatase occur in cholestatic disorders. Take note of that. And elevations occur as a result of both intrahepatic and extrahepatic obstruction of bile flow, and the degree of elevation does not help to distinguish between these two. Alkaline phosphatase levels are likely to be very high in extrahepatic biliary atresia. In acute viral hepatitis, alkaline phosphatases are either normal or moderately increased. Hepatitis A may present as cholestatic picture with either marked and prolonged itching and elevation of alkaline phosphatases. Some tumors may also secrete alkaline phosphatase into plasma. Elevated levels of interstitial alkaline phosphatase have been found in patients with cirrhosis, particularly those with blood type O, and may be associated specifically with intrahepatic disease as opposed to extrahepatic obstruction. Hepatic and bony metastases can also cause elevated levels of alkaline phosphatase. Other diseases such as infiltrative liver disease, abscesses, granulomatous liver disease, and amyloidosis may also cause a rise in alkaline phosphatase. Mild elevated levels may be seen in cirrhosis and hepatitis of congestive cardiac failure. Low levels of alkaline phosphatase occur in hyperthyroidism, pernicious anemia, zinc deficiency, and congenital hyperphosphatasia. Wilson's disease, complicated by hemolysis, may also have very low levels of alkaline phosphatase. The ratio of this alkaline phosphatase and bilirubin is low in fulminant Wilson disease, and this might be as a result of replacement of cofactor zinc by copper and subsequent identification of alkaline phosphatase. And regardless of the cause of acute hepatic failure, a low ratio of alkaline phosphatase to bilirubin is associated with a poor prognosis. It can be increased also by drugs such as metidine, furosemide, phenobarbital, and phenytoin. Gamma-glutamate transpeptidase is a membrane-bound glycoprotein which catalyzes transfer of gamma-glutamate group to other peptides, amino acids, and water. Therefore, large amounts are found in kidneys, pancreas, liver, intestine, and prostate. The gene for gamma-glutamate transpeptidase is on the chromosome number 22, and the levels of alpha-glutamate transpeptidase are high in neonates and infants up to 1 year, and also increase after 60 years of life. Men have higher values than women, and children more than 4-year-old have serum levels of normal adults. The normal range is 0 to 30 international units per liter. In acute viral hepatitis, levels of gamma glutamate transpeptidase may reach its peak in the second or third week of illness, and in some patients, they remain elevated for 6 weeks. In extrahepatic biliary atresia, gamma glutamate transpeptidase is markedly elevated and is only raised in cholestatic disorders but not in bone diseases. In liver disease, the activity of gamma glutamate transpeptidase correlates well with alkaline phosphatase levels, but rarely the levels may be normal in intrahepatic cholestasis, like in some familial intrahepatic cholestasis. Other conditions causing elevated levels of GTT include uncomplicated diabetes mellitus, acute pancreatitis or myocardial infarction, and drugs such as phenobarbital, phenytoin, paracetamol may increase levels of these gamma glutamate transpeptidase. And non-hepatic causes include anorexia nervosa, Guillain-Barré syndrome, hyperthyroidism, and obesity. As a diagnostic test, the primary usefulness of gamma glutamate transpeptidase is limited to exclusion of bone disease, as gamma glutamate transpeptidase is not found in the bone. Other enzymes used here include the serum proteins. The liver is the major source of most common serum proteins. Therefore, the parenchyma cells are responsible for synthesis of albumin, fibrinogen, and other coagulation factors, and most of the alpha and beta globulins. Albumin is the most important of these proteins and is synthesized by the liver and a useful indicator of hepatic function now. Because of the half-life of albumin in serum as long as 20 days, serum albumin is not a reliable indicator of hepatic protein synthesis in acute liver disease. Liver is the only site of synthesis of this protein, and the serum levels are typically depressed in patients with cirrhosis and ascites. In patients with or without ascites, serum albumin levels correlate with prognosis. The normal range is 3.5 grams per deciliter to 4.5 grams per deciliter, and the average adult has approximately 300 to 500 grams of albumin. The serum levels at any time reflect its rate of synthesis, degradation, and volume of distribution. Corticosteroids and thyroid stimulate albumin synthesis by increasing concentration of albumin mRNA and tRNA in hepatocytes. And the serum albumin levels tend to be normal in diseases such as acute viral hepatitis or drug-related hepatotoxicity together with obstructive jaundice. And it can be below 3 grams per deciliter in hepatitis and should raise a suspicion of chronic liver disease such as liver cirrhosis, which reflects a decreased albumin synthesis. In ascites, there may be normal synthesis, but the levels appear to be reduced because of the increased volume of distribution. We have prealbumin. The serum prealbumin levels is 0.2 to 0.3 grams per deciliter, and the levels fall in liver disease, presumably due to reduced synthesis. Because of its short half-life, changes may precede alteration in serum albumin. Determination of this has been considered particularly useful in drug-induced hepatotoxicity. Serum ceruloplasmin is synthesized in the liver and is an acute phase protein. The plasma concentration rises in infections, rheumatoid arthritis, pregnancy or non-Wilson liver disease, and in obstructive jaundice. Normal plasma levels are 0.2 to 0.4 grams per deciliter, and this is an important diagnostic marker in Wilson's disease, in which the plasma level is usually low. Procollagen 3 peptide. The serum concentration of this peptide appears to increase not only with hepatic fibrosis, but in inflammation and necrosis. Alpha-antitrypsin. This refers to a glycoprotein synthesized by the liver and is an inhibitor of serine proteases, especially elastase. Its normal concentration is 1 to 1.6 grams per deciliter. It is an acute phase protein also same as serum ceruloplasmin. Serum levels increase with inflammatory disorders, pregnancy, and after oral contraceptive pills, that is the combined oral contraceptive pills. Liver diseases is usually seen with deficiency of alpha-1 antitrypsin, Alpha-Fetoprotein. This protein is the principal one in fetal plasma in early gestation, but subsequently present at very low levels of less than 25 micrograms per deciliter, and it's increased in hepatocellular carcinoma, and more than 90% of such patients have raised levels. Raised values are found in other liver diseases, chronic hepatitis, in regenerative phase of acute hepatitis, and in hepatic metastasis. And this also raised in adenomas associated with tyrosinemia. We have prothrombin time, PT. Clotting is the end result of complex series of enzymatic reactions that involve at least 13 factors. And the liver is the major site of synthesis of 11 blood coagulation proteins known as fibrinogen, prothrombin, the labile factor, stable factor, Christmas factor, the Stuart-Prower factor, precalcilin, and high molecular weight calcinogen 1. Most of these are present in excesses, and abnormality of coagulation only results when there is substantial impairment in the ability of the liver to synthesize these factors. The standard way to assess these is the stage 1 prothrombin time of quick, which evaluates the extrinsic coagulative pathway. The results of these may be expressed in seconds or as a ratio of plasma prothrombin to control plasma time. The normal control usually is the range of 9 to 11 seconds. A prolongation of more than 2 seconds is considered abnormal. The prolonged PT is not specific for liver diseases and is seen in various deficiencies of coagulation factors such as DIC, that is disseminated intravascular coagulation, and ingestion of certain drugs. In acute and chronic hepatocellular disease, the prothrombin time may serve as a prognostic indicator.